I'm Dr. Barbara McElhanon. I'm a pediatric gastroenterologist. I'm the medical director for the feeding program at the Marcus Autism Center. And today I'm going to talk about transitioning off of tube feeds to oral feeds. So for most parents, as soon as the tube is placed, they start asking questions about when their child can get off of tube feeds and start transitioning back to oral feeds. And some families, understandably, are more concerned about the other medical things going on with their child and really aren't so concerned about transitioning to oral feeds until later on. For a child to take food by mouth, he or she needs to be able to accept it, manipulate the food in his or her mouth, and then swallow it safely. And so for some children, when they're allowed medically to start eating by mouth, they do this transition very easily. And some kids don't do it so easily, and that's when we start talking about things like oral aversion, which is a term you may be familiar with. So oral aversion is just like it sounds. It's a child not wanting to put foods into their mouth for various reasons, and it's mostly a behavioral component of feeding. The reason that that happens is because the child has paired feeding with a negative experience. The negative experience could be painful or discomfort or even psychologically uncomfortable. And even when those issues are gone, such as if your child had esophagitis and then there was a follow-up scope to prove that the esophagitis is gone, that the child is still pairing negativeness with the feeding experience and is still persisting with not wanting to eat. And understandably, but unfortunately, parents and caregivers who are the main feeders sometimes reinforce this behavior. So common negative behaviors that children do when they have aversions are spitting during meals, vomiting, gagging, screaming, crying, saying no, pushing their caregiver's hand away, getting up and leaving the table. And so especially in kids with other medical problems, caregivers assume that there's something ongoing that's concerning, and so they will stop feeding the child, which further reinforces that the child's doing the right thing to try not to eat. And so it really, you develop a child that's really, really good at not eating what they don't want to eat. And you, as you know, if you're watching this video and are concerned about this, it can be, you can't force a child to take food and chew it and swallow it if they don't want to. So the major point when I'm thinking about transitioning a kid to oral feeds is to try to prevent any of that, if at all possible, from happening. And unfortunately, there's not that much research to it, but what I've learned from experience and some research is that early on in the process, when your kid first has a tube, thinking about keeping feeding and oral feeds on the list, on the medical list. So usually your child's going to have a couple medical problems. They need to have their nutritional needs met. But on the list is that eventually you'd like your child to eat everything by mouth for their full caloric and fluid needs. You bringing it up and advocating for it will make sure that the physicians and speech therapists are always thinking towards that. As you can address the other medical issues and make sure the nutrition is good, and the other medical issues are treated, like let's say your child has a cleft palate and they have surgery to repair it, then feeding can be more aggressively addressed in the future. Other ways to think about early on is to always have a speech therapist or an oral motor therapist involved who has expertise in feeding. Even if your child's not allowed to have anything by mouth, they can use empty spoon and usually almost always a small amount of water. Having a dietitian on board to help you know how you could transition off feeds, and having a pediatric gastroenterologist involved early on is really helpful because we're really the experts in feeding and nutrition and can advocate for your child, especially if there's other medical concerns going on. So the real issue is, when do you need more help than that initial help, and when does it look like behaviors are a problem? And some people say 3, some people say 6 months, but somewhere in that range, if your child is not making progress with the current oral motor therapies, it's time to be more aggressive. So that may be reconsidering who the speech therapist is or occupational therapist and seeing if there's someone who could be referred to who has more feeding experience. Checking back in and making sure there's no medical reasons that your child is not eating like they should or is refusing food. So that may be checking back in with the pediatric gastroenterologist, and even pediatric ear, nose, and throat doctors are experts in this area. If tests are required to make sure that your child doesn't have a medical cause for food refusal, and presuming that they're normal or those issues get addressed, then you're left with a child who has a mainly behavioral issue. And the research does support to address behavioral feeding disorders. You need a multidisciplinary clinic that has a behavioral psychologist, speech therapist, or occupational therapist, a pediatric doctor, sometimes a gastroenterologist, and dietitians, and usually nursing support. Those programs have really good results. Unfortunately, they're few and far between. There's not a ton of those programs in the country, but that's why I think that it's important to go ahead and refer yourself to those, because the wait list can be long, and there's no harm in initiating that process early on, and hopefully you will never need to go to a program like that. It may be that the issues get sorted out before that. So to summarize, make sure I hit all the high points. So start asking questions about oral feeding as soon as the tube is placed. Do your best to be patient. You can make the parent-child feeding interaction worse by focusing too much on this aspect of his or her care. Don't hesitate to get a G-tube if your child's been on a nasally placed tube for more than 3 months. Feeding can be addressed with more aggressive treatment as other medical problems are solved. Use dietitians and oral motor therapists as a first step. Seek more medical workup if there's no progress after 3 months or so. And don't hesitate to start investigating feeding programs early in the process, knowing that oftentimes there's wait list for evaluation and no risk to initiating that process.